So we're going to continue Jorg's talk on artificial intelligence and expand this to, yes, whoops, back. What would Sampson say? So I have no disclosures. There were a lot of learning objectives. The only one that's important is the one that's highlighted. Remember, when we're talking about recognition, this is a surrogate measure. This is blue sky. It doesn't mean that we need to treat it. Recognition and treatment are two different subjects. We need more data on what it means to treat specific lesions. We're going to talk about basic research, translational medicine, expert opinion, and speculation. If we go back to 1899 and we look at, which one? That one. And we look at Richard Russell's original discussions of hidden endometriosis. Remember, this is endometriosis he didn't recognize. This was an ovarian cyst, adenocarcinoma on the left side, right side, normal size, outer pole surface covered with shreds of adhesions. Endometriosis hidden beneath the adhesions. Endometriosis hidden near the hilum. As far as I know, we don't have an MRI, a sonogram, anything else that is capable of seeing lesions at that size. What was missing from Jorg's, which is missing from every discussion I've heard on sonograms, is the range of the sizes of lesions that are being found, the median lesion that is being found, and a distribution of the lesions being found. Everything that I see looks like you're looking at 2 centimeter lesions and you're missing an awful lot of small ones. We miss endometriosis all over the place. I'm going to show you some examples of those on the peritoneal surface, retroperitoneum. You just saw the ovary. We miss it all these other areas. We are not good at recognizing endometriosis in all patients. We're pretty good at peritoneum. We can see what's in front of our face. It's what's not in front of our face that we miss. There are lots of ways to miss it. For those of you who don't understand, I rarely did bowel endometriosis laparoscopically. I used laparotomies through my entire life. I think that a surgeon who doesn't understand when he needs to do a laparotomy or at least a hand-assisted laparoscopy so he can palpate is not competent in identifying endometriosis. And I understand that that goes at odds with half this room. But I think if you don't use something to try and palpate inside the abdomen, you're missing lesions that I found my entire life. Things like Mark Passover and others. We have, whoops, wrong one, this one, that one. There are people who find, well, one of these buttons is going to do it. We find people who find endometriosis dissecting. So these subtle occult peritoneal pockets in endometriosis found while they're dissecting areas. Mark Passover, who only finds them because he's done all of this interesting data that he does to find out where recognition is. All of these are reasons that we miss endometriosis, things that we don't think about. Techniques are wrong. I still see videos of somebody taking a coagulation, a vaporization unit and starting in the middle of the lesion and vaporizing it from the middle out. We did that in 1982 and realized by 83, this is the wrong approach. If you don't start on the outside and work in, you've got to mark the lesions from the outside and work in. Otherwise, you distort the outside so much you can't find it. Tamara will not like the fact that I have not fixed my slides yet. I still call these satellites because V.C. Buttram called them satellites. This is multifocal endometriosis. This is the problem that David Redwine and I had. And I'll show you pictures of what I had. Remember in David Redwine's 1991 paper, of the 35 new diagnoses he had, 33 were because of tunnel vision. He could go back and look at his old pictures and see these were lesions he missed because he wasn't looking at them accurately enough. So this tunnel vision is a big problem. Palpation, magnification, all those other things are important. This was my protocol. So those of you who've seen my study that got up to a 99% predictive positivity. Remember, it had a 14% negative negative positivity. So I had a lot that I missed, but that was the protocol that it took. Nobody can do that in clinical practice. When I went back to clinical practice, I dropped from 99% back to 88%. You can't hold that kind of technology if you're doing research. I mean, you can do this in research, you can't do that in clinical practice. And then we get into, we want to make Paula and Sunway happy. We got to have some more markers for fibrosis. Too many green buttons in here. For fibrosis, we have to have all these additional things. And then for inflammation, remember, on real subtle lesions, you can't tell the difference between an inflammatory cell and a stromal cell. They look just alike. Need CD10s and other markers, other histochemical markers, or we don't know how to do it either. Look at some specifics of this. In Griffith's study, 14 of the 16 cases of rectovaginal endometriosis they did had been missed at previous surgery. 14 of 16 missed at previous surgery. People who looked at them laparoscopically and missed it. Question is, how many of these will imaging demonstrate? I'll show you one shortly that imaging will demonstrate because it's large enough. But how many of those will recognize it? How many of them are going to miss? Because until we know that they're capable of, remember, we found plenty of palpable 3 to 5 millimeter nodules. Until they're capable of doing that routinely, then I'm not sure what we make of those. This is a study, napkin ring lesion. And for those of you who don't understand napkin ring lesions, this looks like a cancer. To a radiologist who looks at this looks like a cancer down here. You got something sitting right there that doesn't belong right there. A hole in the bowel. So somebody calls me up after this bare minimum is done, the radiologist missed it. So this was missed on the original x-ray. They subsequently did a laparoscopy and missed it. They did a laparotomy and missed it. Then they referred her, then they repeated the bare minima and found that they found the same thing, but they didn't compare it to the original. They called me up because this is what we were talking about before. They had told me that I had taught them you don't get this in less than 7 to 20 years. This takes 7 to 20 years to develop. This is not an immediate development. Something this size takes years to develop. And they called me up to tell me they'd found one in it developed in 2 years. So I said, have them review the films. Apparently the radiologist turned white because he thought he'd missed a cancer. So these massive size lesions that people who are doing imaging. So when Jorg talks about experts, I can have a medical student do this one if he's looking closely enough. We need something more than experts. We need people who are paying attention. This one, which I love, is Philippe's paper, Philippe's image from 1989. We have a 15 millimeter nodule right there. Easy to palpate. Philippe picked it up on clinical exam. He knows it's there. He knows where it is. He can palpate it and map it. So he knows when he goes in, he knows that's where he's going to look. And after he dissects, that's what he sees. 15 millimeter nodule. Sonograms can pick that up. MRI can pick that up. Physical exam can pick that one up. Someone who's doing a good retrocervical exam will have no trouble finding that one if you don't do it. Remember, the current WRF thing doesn't include retrocervical exams. I'm not sure, but they're going to miss this thing on that technology. But that is something that imaging is capable of picking up until it gets to a certain lesion. I keep hoping they can see a 5 millimeter or smaller lesion, like this one. Little endometriotic nodule from Den. This is Lenardi's group. They found it on sonogram. They went into laparoscope, had a normal uterosacral ligament. And with a normal uterosacral ligament, they decided to excise the uterosacral ligament, and that was endometriosis. So we have lesions like this that we know that we can see now. Yes, I promise you I can make this thing work. Right there, we can see these 5 millimeter lesions on the uterosacrals, but we need to know how often is this, and it's just an oddity. We know that imaging has been adequate for that, was inadequate for 15 millimeters in 1989. Would have been. I don't know if did you use imaging on that one, Philippe, or not? We weren't even using imaging then, were we? That napkin ring lesion they missed, Now we have that sonogram for the hidden uterosacral ligament we found, and we now have Lenardi's found us some 2 to 4 millimeter peritoneal lesions. But as far as I know, other than occasional incidental 2 to 4 millimeter lesions, we don't have any data more than that. Again, I've got to fix my slide before Tamara shoots me. These are multifocal endometriosis, not satellites. VC Buttram thought we should do 1 to 2 centimeter margins to make sure we got them, because he said they were hard to find. Larry Demko found pain 27 millimeters away from the peritoneal lesions he could see. Badusco et al. And Roman et al. Found hidden satellites up to 6 centimeters from a primary bowel lesion. And in Badusco's original study, she had up to 36 hidden lesions in and around the originals. As an example, this is one, most of you have seen this picture a million times. How many of you have seen this dark scarred lesion right there? How many of you recognize it as a dark scarred lesion? But if you look at it closely enough, that is a dark scarred lesion. And you can barely see the darkness in it. There's a little dark area here, and I can't see it on this slide, but I can see it in the originals. That is a dark scarred lesion. The chance that's endometriosis approaches 100%. But what we didn't see in that slide is there's a little vesicle down there, a little bitty fibrotic lesion here. Those are all endometriosis. And all these abnormal areas, little vascular abnormalities, everything else in here doesn't look right. And in Albee series, 24.3% of abnormal areas were endometriosis. So when we start programming these artificial insemination things, artificial intelligence things, we've got to program not only the things we know how to describe, but also these other subtle abnormalities. We have to be ready not for the 6 descriptions in the ASRM, the 20 descriptions I had in my study, but we have to be ready for all 68 that we found in 16 different studies that we analyzed to see how many different descriptions there were. So there are 68 different unique descriptions, all overlapping on different ways people see things. I was able to get down to 200 microns. We had glands and stroma on a 400 micron, glands only on a 200 micron. I wish I had a CD10 on the base of that, but I don't. But in addition to being able to see down to 200 microns clinically, when we blew this up in the lab, we can see as small as 80 microns sitting right there. Do I know what that 80 micron lesion is? I don't know. It could be an artifact in the picture. Could be an inflammatory rest. Could be endometriosis. Could be cancer for all I know, because all I know is it's there, but I don't know what it is. Tamer, when he showed that slide yesterday, one of the lesions in his was 30 microns. That's at the 2 to 3 cell size. We need some way to technically tell what those things are so that we know what they are, just to be able to recognize them. And as I said in the beginning, after we recognize them, then we have to prove that means something. Recognition is still blue sky. That's not translational. We need somebody to do the translational work that shows that what we can recognize means something clinically. So we're going to get improved outcomes from artificial intelligence and all of those things that it can do. Some of the biggest are you don't worry about how much learning curve somebody's on, because the computers are going to be learning curve at the top all the time. We're going to have all these concerns. I think the fallacious extrapolation was the one that hit me the most in the beginning. That was the one when you ask it to give you PubMed citations for papers. It did the same thing to PubMed citations that it did to text when you turn it into a limerick, a haiku, any other kind of prose poetry. It rearranges the citations. I asked it for citations. It gave me my citations written by Cameron Najat and vice versa. It gave me citations that did not exist. It did the same thing to legal citations. They disabled that module about 6 months ago because it was such a big national disaster for them. But all these other problems, and the one that I didn't understand was this one. Nobody in this room has a trouble seeing that stop sign. Does anybody in the room have a trouble seeing that that's the same stop sign? Artificial intelligence cannot tell the difference. Excuse me, artificial intelligence misses the second one. Artificial intelligence trained on this one cannot see This one. It's the same problem that Tesla had that went after one of those silver 18-wheel trucks. It picked up the blue sky reflection on the side of the truck and read it as sky and not as a truck. You got to watch for these things. These things are going to take a lot of work to work for. Conclusion one, we've got to be happy to watch for our learning curves and what we feed into them. We have tunnel vision, so we're not finding everything. We hope that we can tell it how to find them. The satellites, the multifocal, the small lesions, they are going to be able to help us with physician fatigue. So we don't worry about a physician who's been working for 16 hours, all of a sudden wearing out and not being able to see where he is. The time sensitivity to development of everything, the computer models are going to see things without worrying about that, and they will be continuously learning. We have a lot to work with. We've got to get biomarkers in there, the historical surveys, all those other things we have to do. They do need to be a part of comparative research, and we need to be prepared for what we're going to do if it really works. I think Sampson would say right now we're not prepared. Thank you.